evening. Good evening. My name is Eve Kleinerman. I am the Illinois Regional Director for Share, and I want to thank everybody for joining us this evening for the latest in our webinar series, Highlights from ASCO of 2023. For those who may not be familiar, ASCO, the American Society of Clinical Oncology, is the world's leading professional organization for physicians and oncology professionals caring for people with cancer. And tonight we are privileged to be learning from Dr. Yuan Yuan and Dr. B.J. Reimel, two nationally recognized physicians representing Cedars-Sinai Cancer Center, who will highlight the latest findings from the American Society of Clinical Oncology's 2023 annual symposium. We are grateful to tonight's webinar sponsors, GlaxoSmithKline, Daiichi Sankyo, Gilead, and AstraZeneca. Before we begin, I just want to cover a few housekeeping items. The first of which is that tonight's webinar is being recorded and will be posted on ShareShareIt's website along with a transcript. However, participants' faces and names will not be in the recording. But if you would like to remain private, you can turn off your video and rename yourself, or you can call into the webinar, and instructions for both of those are in the chat box right now. You may have noted that all participants were muted upon entry. Please keep yourself on mute throughout the presentation. And if you have questions, put them in the chat box, either publicly, or you can message myself, labeled as ShareShareIt, in the chat box to submit a private question. We received many questions in advance of the webinar, and we do anticipate receiving many questions in the chat box. And so we will do our very best to answer all questions tonight. But any questions that are not answered for you tonight on the Zoom will be addressed by email over the next week. We recommend for the best viewing that you keep your screen on speaker view, which will allow you to see the doctor's presentations. You can find that option in the upper right-hand corner of your screen. As we move into the webinar itself, I do want to remind you that ShareShareIt is a national not-for-profit cancer support and education organization, and we do not provide any medical advice or perform any medical procedures. This information provided by ShareShareIt is not a substitute for medical advice or treatment for a specific medical condition. You should not use tonight's information to diagnose or treat a health problem. And if you do have questions that are specific to your medical care, the physicians on screen may not be able to advise regarding specifics and would advise that you speak to your medical provider. Always seek the advice of your physician or qualified healthcare provider with any questions you may have regarding a medical condition. In just a moment, I'm going to introduce our presenters to you, and they will give their presentations, followed by a question and answer session. And after that, we will immediately begin our special bonus breakout program with our Embrace group for those who are facing metastatic breast or advanced ovarian cancer. Anyone facing advanced disease is invited to stay on for an intimate breakout session with Dr. Yuan and Dr. Reimel, and a conversation that will be moderated with Bonnie Beckoff, our Director of Support Services. And now this evening, we are so honored to be joined by Dr. Yuan Yuan and Dr. B.J. Reimel. Dr. Yuan Yuan is a breast medical oncologist and physician scientist who specializes in triple-negative breast cancer and breast cancer immunotherapy. Dr. Yuan currently practices at Cedars-Sinai Comprehensive Cancer Center and is also working closely with the Cedars-Sinai cell therapy team to bring first-class immunotherapy treatments to patients with solid tumors, including breast cancers. Dr. B.J. Reimel began working at Cedars-Sinai Medical Center in August 2011 to focus on gynecologic oncology clinical trials. Dr. Reimel's research interests focus on barriers to clinical trial enrollment and use of digital processes to improve access and comprehension of clinical trials. Dr. Reimel is the gynecology surgeon of the Cedars-Sinai Transgender Program, and Dr. Reimel is also the medical director of the Cancer Clinical Trials Office. Both physicians' full bios are available on our website. And now I turn your attention to Dr. Yuan Yuan.
Thank you so much, Eve. Let me share screen. All right. Again, it's a great pleasure to be here tonight, and I'm so happy we're able to spend some time to discuss ASCO update. And I tend to speak too fast, and but thankfully there is a breakout session. We can further clarify any question if it wasn't clear. So the outline, we're going to spend time on mainly 3 trials to discuss the early stage ER positive, maybe potentially breakthrough therapy, which will be the second CDK4/6 inhibitor in the space. Then we'll discuss our exciting patritumab deruxtecan, which is a HER3 antibody drug conjugates, and then go over some of the mature data of TROPiCS-02. Then if we have time, we can talk about two ongoing studies happening in CEDARS. So those who's familiar with breast cancer treatment, I think the CDK4/6 inhibitor has been there since 2016, for the last 7 years. It's moving now from the metastatic space to the adjuvant space. The idea behind is that while patients are doing better and better in the metastatic setting, can we do this in our adjuvant setting to prevent the breast cancer recurrence? There are some nuances about the three drugs. They're not exactly the same. So on the right-hand side, you see this pie chart is really looking at the mechanism of the drug. They don't even look like the similar. So especially this abemaciclib or Verzenio, it tends to have a bit more toxicity. Patient can develop diarrhea. So you can see that it has a broader target. So that being said, currently abemaciclib is the only FDA-approved agent for high-risk early-stage breast cancer patients to take 2 years to prevent breast cancer recurrence. So we do have some exciting new data coming out of this initial Johnston et al. 2020 trial. So, and further follow-up really confirmed. Now we have 4 years data. We're talking about patient surviving without a disease recurrence. So that's, reconfirming the benefit. And how about the question is, how about the next or other two? What are they doing? So in this ASCO 2023, it's first time a long-awaited phase 3 clinical trial now studying the second CDK4/6 inhibitor called ribociclib. Commercial name is called Kisqali. So in this trial, shown on this graph, patients were compared. It's a large study, 2,500 patients each arm. Ribo dose is a lower dose comparing with metastatic setting. It's a 400 milligram daily, 3 weeks on, 1 week off, and also different from abemaciclib. This is 3 years of treatment. And then the control arm takes only aromatase inhibitor. So these are the stage 2A or 3 patient who had ER positive or hormone receptor positive HER2 negative disease. They have certain high risk features, including a high oncotype DX, perhaps other genomic profiles, or they're lymph node positive, or Ki-67 over 20%. So this trial, and then there's some granularity of the data. 27% of the patients were node negative. This is very important because the abemaciclib only applies for lymph node positive patient. So this is good and bad. So our high-risk node negative patient now potentially will soon have this drug available if FDA approves it early next year. So I think that's an important distinction between ribociclib trial and abemaciclib. And there's some more granular information regarding the toxicity, the reason for discontinuation. Granted, these are well-tolerated treatment, but there are certain adverse events led to the patient stopping the treatment. And this is the primary readout, evasive disease-free survival, meaning one would remain healthy without any recurrence of breast cancer. You can see that in such a short follow-up of 3 years, there's already a difference of 3.3%. It may seem to be relatively small, but that translates a risk of invasive disease decreased by 25%. So hopefully in the future, we'll see more follow-up and even eventually it will be overall survival data. And also translate the clinical trial data highlighted in red is the risk of distant disease recurrence was decreased by 26%. So it's further helping these women to prevent metastatic disease. Now the toxicity, perhaps our audience is familiar with this drug. It's a oral inhibitor. It's not a conventional chemo, but it does reduce the white cell count, especially they're not trivial. In the metastatic setting, when patients were given 600 milligram, there's a lot higher grade 3 events, but here it's reduced, but it's still not trivial. In addition, the table listed a number of toxicities, and but the highlight is that it's reduced comparing with metastatic setting. So not going into all the weedy discussion, the take-home message from this trial is that the NATALEE trial supported ribociclib in a lower dose in combination with aromatase inhibitor as a potential new adjuvant treatment options for patients with stage 2 and 3 hormone receptor positive early stage breast cancer who face a higher risk of recurrence. So currently not yet FDA approved. And is this practice changing? So this is a very important question. You know, after ASCO, we take this data home, and then we see the patients next week, and then we discuss them in the clinic. I, in fact, have patients had completed 2 years of abemaciclib, and she asked me a question: can I switch to ribociclib and then do additional year? So this is a lot of, you know, interesting question. We may not have all the data to support, but certainly consider ribociclib in patients with high risk who missed the Monarch E, which is an adjuvant abemaciclib eligibility criteria. So in order for us to understand a little better, so we did this table to compare. So you can see that definitely this 2 trial covers similar population, but granted, for those, for example, the T2N0 nodal negative patient was not included in Monarch E. The T3N0 patient was not included in the Monarch E's, but now this is opening up the options for them. So this is a welcoming changes. So we're gonna move on to the next is, we're gonna move on to the really exciting area in breast cancer and beyond. This is called antibody drug conjugates. Here in the middle, it's just showing the structure of the drug. So the Y-shaped antibody is in the middle, and it's specifically designed and chemically bonded or linked to chemotherapy drugs. So the yellow little spheres are the payload or the chemotherapy drug. So right now we have multiple agents already FDA approved and many to come. So for example, the trastuzumab emtansine or TDM1 was approved many years ago to treat HER2 positive or HER2 amplified breast cancer. And then we saw sacituzumab govitecan, now it's FDA approved to treat triple negative breast cancer, and also in hormone receptor positive, previously chemotherapy treated population. Then what's in the clinical trial setting is trastuzumab deruxtecan, or TDXD. It's soon coming. And then we have this exciting update from this ASCO, which is a HER3 antibody drug conjugates. We're going to go into detail in a bit. So this is, again, a different format, highlights all the drug available at this moment. And TROPiCS-02 is, in fact, this what's in the middle. You don't see my cursor. This is blue, bottom left down. This is the SN38 payload. The antibody is a humanized anti-TROP2 antibody. So what is TROP2? TROP2 overexpresses on the surface of cancers, especially breast cancer, or in triple negative breast cancer, it's overexpressed in 90%, in hormone receptor positive over 80%. So obviously this differentiates the cancer cell with a normal cell, so that can naturally become a target. So the data initially came from ASCENT trial showing in second line or third line setting, triple negative breast cancer patient, the drug definitely improve and control the disease. There's overall survival and progression-free survival benefit that led to the very initial FDA approval. And then the TROPiCS-02 trial is actually looking at a different population. So can this drug benefit patients who is hormone receptor positive, but had, went through over, oftenly 4 or 5 lines of therapy, including multiple lines of hormone-based treatment. When they move on to chemo, eventually they may need something new. So this is a trial design for these patients who already progressed through multiple lines of chemotherapy. And the final update this is the recent ASCO update to show the overall survival benefit. Trial design very straightforward, and notice that these patients are relatively heavily pretreated beyond the conventional endocrine treatment. They also received average 2 to 4 lines prior chemotherapy. So total over 500 patients were randomized to receive sacituzumab govitecan. Commercial name is called Trodelvy versus physician's treatment choice, single agent chemotherapy. And the primary outcome is looking at the progression-free survival. I want to draw your attention to this table on the right hand and the last row. Look at the median prior lines of therapy. You can see that they're relatively heavily pretreated, ranging from 0 to 8 lines of treatment, for example, in the SG arm. So this is the updated progression-free survival. You can see that the curves are separating at 6 months of time. 45% of the patient in the Trodelvy or sacituzumab govitecan arm did not progress. In contrast, was 29% in the control arm. And the further follow-up, you can see the distinction at 18 months. 14% of the patients were stable with the new drug versus conventional chemotherapy, only 4.7%. So that's a meaningful differences. And further subgroup analysis and breaking down into overall survival. And actually title, I apologize, it was a mistake. It's overall survival. You can see that the overall survival meets its primary goal, and the p-value is significant. And then you may ask, does it really matter how high? So H-score here is really talking about TROP2. So we're now familiar with HER2 expression, high, low. So does the TROP2 high, low make any sense and make any differences? So this is to give us, some ideas when patients have either low score versus high score. You can see that numerically in the high score group, they appear to do better. But although even the low score group, there is a small difference is brought on by the drug. So I think at this moment of time, the FDA approval do not ask for TROP2 testing. So we all do ERPR HER2 testing, but we don't do TROP2 testing. And a response rate, I have to say, even in the sacituzumab govitecan arm, the response rate 21% is not super satisfying, but it's slightly better than the physician's choice arm. The toxicities, there's some breakdown of the detailed information I won't spend too much time on. And toxicities, GI toxicity is not trivial from SG or sacituzumab govitecan. Diarrhea, nausea, vomiting, abdominal pain can be found. And there's clearly we need to pay attention to these symptoms. So the outcome in the conclusion is that the phase 3 TROPiCS-02 trial in hormone receptor positive HER2 negative metastatic breast cancer continue to confirm the benefit in reduce the risk of progression, and no new safety signal were seen. So I think it's worthwhile to bring this drug into discussion with a physician for appropriate patient population. So more excitingly, now we heard about HER2, TROP2. What is HER3? So what is HER? HER is human epidermal growth factor receptor. So there is actually a silent HER family, including HER1, also called EGFR. It's talked a lot in lung cancer. HER2 is famous for breast. And there's HER3 and HER4. So I apologize, I didn't bring you a cartoon here. So the HER3 is not silent bystander. They play a very important role. They would form the teamwork or forming this conjugates together with HER2 to help the HER2 signaling passing down the surviving signal. So the reason this becoming interesting is that in the past, we don't talk about it because there's no drug to target. Now, finally, we have the drug. So this drug is called a HER3 antibody drug conjugates. So the antibody is called a patritumab, and the payload is deruxtecan. So this is a very much the same payload as TDXD, trastuzumab deruxtecan, the star drug last year. So this is a few trials already been ongoing, and this ASCO we saw a continuation of signal coming from a phase 1/2 trial and really, showing us the efficacy. And I was leading the trial at my previous institution, was a robust enrollment, and we have really good patients coming out of this study. So it's a complicated 3-phase trial, but at this moment of time, in this ASCO, we're seeing the part A, which is a fixed dose. The drug is 5.6 milligram per kilogram intravenously given every 3 weeks. And patients could be hormone receptor positive or triple negative breast cancer. The only thing that is that they cannot have previously antibody drug conjugates who, for example, patient with HER2 low disease already received in HER2. In this trial, they're not included. There are going to be tons of research questions in the future when we have several drug FDA approved. How do we sequence them? So coming back to the trial, the HER3 expression was studied, and you can see that over 60% of the patient have a high HER3 expression, over 75% in their treatment, and they're relatively also heavily pretreated. Over 60% of the patient had received 3 lines or more prior chemotherapy. And efficacy data, and there's a lot of granularity of information, but the key message here is that regardless of the HER2 expression level, in the red box, you see a somewhat similar response rate. Focus on the PR, the second bullet point. So in HER3, over 75% patient, you see 33% response rate. But even when the HER3 level is lower, you see the response. So this is, again, a recurring theme, is that regardless of these receptor level, they seems to be all effective. Now, not enough information in this trial to draw too much conclusion of a triple negative versus ER positive disease. So we need to be staying tuned for more information. Now, those who's familiar with TDXD may ask a question. TDXD has a FDA black box warning regarding 10% of patients develop a potentially life-threatening toxicity called ILD. What about this drug? So naturally, this is the first question. Now you can see that the right upper box showing that SAE ILD risk, only 1 patient in 60 patients totally accrued, so relatively low percentage, although the number is too small here. The drug is very well tolerated. I remember my first patient went on to this trial. She came from a different institution. She was the one possibly mask this toxicity. Every time she come in, no complaints, no hair loss, no nausea, vomiting. But if you look at the table here, 50% of the patients have all grades nausea, but the grade 3-4 severe nausea is very low. Fatigue 6.7%, diarrhea is 5% only. So again, I think the toxicity profile take-home message is very safe, very well tolerated. So in the bottom line is that this is another ADC may enter your, get your attention. I think that's worthy of discussion for anyone who needs another novel treatment. It's time to discuss, perhaps, seek these trials out. So I'm gonna, if I have time left, I'm gonna quickly talk about the algorithm for hormone receptor positive, HER2 negative metastatic breast cancer treatment. This is actively getting updated all the time. And you can see that the green, the first row, is pretty standard frontline treatment, CDK4/6 inhibitor, first column. And then second line, moving on. Now we finally have some, I would say, personalized or precision medicine driven approach. We now have, if patients have ESR1 mutation, they can get oral SERD. If the patient who are BRCA positive, which is near and dear to our heart, and Dr. Raimo will touch upon these patients. So the BRCA positive patient can certainly get olaparib or talazoparib. If the patient PIK3CA mutation, they have a specifically targeting alpha-specific PI3K, alpelisib or Piqray, and then good old everolimus is still there, plays a critical roles, and then they have like 2 or 3 lines of options and can move on. And then if they have to move on to chemotherapy, then it's the space that they can either get standard care capecitabine or consider HER2 low treatment. You can see that the TDXD in purple, a 4th line, be there, 5th line, sacituzumab govitecan, and more importantly, there are some interesting investigative drugs such as capivasertib, the rumor is that we may get approval later this year or beginning of next year. There's another drug targeting PI3K AKT-mTOR, and stay tuned for all these red color. They're investigational. So if I may, I'm going to take the really quick seconds to talk about 2 ongoing trials. I'm sure this group is super familiar with PARP inhibitors. It's sort of, taking a second hit for this cells already carry the BRCA mutation. They're already defected in BRCA DNA repair complex, and the PARP inhibitor had shown to have a progression-free survival benefit in metastatic disease in patients harbor this mutation. And the drug is currently already FDA approved to treat residual cancer after neoadjuvant chemo. So what else is going on with PARP inhibitor? How can we leverage this drug? So we knew that from the preclinical experiments. It's a busy slides here, but the far left is showing that in the preclinical setting, PARP inhibitor is not only working on DNA repair mechanism, it can also turn immune cold tumor to immune hot, perhaps to help immune checkpoint inhibitor to work better. So there's tons of evidence. And then there's 2 small trials, including durvalumab in combination with olaparib, immune checkpoint inhibitor, and also niraparib, currently in the ovarian cancer space, FDA approved, in combination with pembro, showed an interesting signal. So at Cedars, my colleague, Dr. Monica Mita, has run a trial combining olaparib with pembrolizumab. She's still actively enrolling patients, but she opened up a little bit more, not just limited to BRCA mutated patients. If anyone through genomic testing shown HRD, homologous recombination defect positive, these patients would also qualify. And regardless previous PARP inhibitor or immune checkpoint inhibitor treatment or not, there's perhaps a second opportunity to re-exercise this combination. So if there's an interest, let us know. And I have worked with my colleague at City of Hope before joining Cedars to looking at drugs can turning immune cold tumor to immune hot. So we are repurposing this old drug called ivermectin, being since 1970s being used for parasitic treatment in Africa, worldwide for river blindness. So through aggressive NCI drug screening, preclinical mice model, we found that this agent can turn immune cold tumor on the left into immune hot. So after ivermectin treatment, you see these yellow dots are the T cells. So the cells initially were surrounding, they can't enter the center of the tumor, they can't take action. But now after ivermectin treatment in this mice model, you see lots of tumor infiltration, and then you see the tumor actually getting so much smaller when you combine the ivermectin plus immune checkpoint inhibitor. And after tumor disappear, when you're re-challenging the tumor in the bottom right, when you're re-challenging this tumor with a mice patient, you found that the actual tumor cannot grow. So that is very interesting, intriguing. We were funded by Gateway Foundation to run this phase 1 clinical trial. We're actively looking for patients. So it's oral ivermectin plus the intravenously a PD-1 inhibitor called balstilimab. So I'm going to stop here. Thank you so much. I hope I didn't talk too fast. Thank you.
Thank you so much, Dr. Yuan. It was wonderful. And I am now going to welcome Dr. BJ Rangel.
Hi, thanks for having me. I'm going to share my screen. Hopefully I get it right. Did it work?
Yes, perfect.
Hooray! It's always the miracle part of the talk. So I'm going to give a very brief ASCO 2023 update. In ovarian cancer, we have obviously a lot less patients, and so we have a lot less to talk about, especially as it relates to ovarian cancer. We had a very exciting trial come out this year that led to an FDA-approved drug. So I'm going to share that single trial, but try to hopefully break it down into its pieces, talk about why this trial is important, what's different about it compared to some other clinical trials, and a little bit about the drug toxicity. And in all fairness, I got these slides from my very dear friend, Dr. Kathleen Moore, who is actually the principal investigator of this international trial. So hopefully this is moving forward. Nope. Okay, new plan. Let's try this. Oh, it worked now. Okay, excellent. So as Dr. Yuan excellently mentioned, we have antibody drug conjugates. And these are really paradigm shifting new molecules. So as she mentioned, antibody drug conjugates are these amazing molecules that have both chemotherapy attached to a molecule that binds to a protein of interest. So anything that's expressed on a cell that you don't like, you can target this particular drug to that cell. And that's really where the magic is. And in GYN oncology, what we're seeing is that our treatments are becoming more individualized. We have PARP inhibitors for patients that have BRCA mutations or homologous recombination deficiency. We have immune checkpoint inhibitors for our patients with endometrial cancer that are MSI high or mismatch repair deficient. We have these new antibody drug conjugates that are really our new frontier, and they really allow us to target specific tumor antigens. So specific proteins that are hanging out on the cell surface membrane that allow us to unlock that cell and dump drug inside. So these are what they look like. As Dr. Yuan already mentioned, you have this Y. At the top of the Y are really where the binding sites are. They bind to the surface of the cell. The linker is the thing that breaks off in the cell and dumps the drug inside. And the goal is that when you dump the drug directly into the cell, that you get less systemic toxicity. So hopefully what happens is cancer cell dies and patient feels better than they would on regular old intravenous chemotherapy, which isn't really targeted. So on to the fun stuff. This is ASCO 2023's phase 3 Mirasol study. Mirasol was combined with the European group as well as the American group. And the name of the drug is called mirvetuximab soravtansine, or you can call it just MIRV for short, because otherwise it takes a really whole lot to say. This was for epithelial ovarian cancers and primary fallopian tube cancers. They look the same under the microscope. They all get lumped together. And they all in this particular study had to have expression of high folate receptor alpha. So the protein of interest, the thing that Y binds to, was folate receptor alpha. Okay, so why did we do this study? Because unfortunately for ovarian cancer, metastatic disease is very difficult to treat. And we have not been able to realize an improvement in overall survival for the last 30 years of research. And so we've not had a phase 3 study that demonstrated that. And this is the first time that's changed. It turns out that folate receptor alpha is expressed on most ovarian cancer cells and highly expressed in at least 35 to 40% of primary ovarian cancers of the epithelial subtype. And previous studies had demonstrated that this was true. Folate receptor is not new. We were super excited about it, and thus this study became a real thing. So folate receptor as a target in oncology, as I said, is not new. And if you are an ovarian cancer person, you know that these old drugs, pemetrexed, used to be a big thing, and that's supposed to target folate. We use methotrexate, which is supposed to target folate. There's tons of things that we've used in the past, but none of them been as as targeted as this new agent. And so this research is really focused on using this particular highly expressed protein to find drugs to attach to it. So Mirasol is the study. The patient population is that they had to have recurrent endometrial cancer, and they had to have, recurrent ovarian cancer, and they had to have folate receptor high platinum-resistant ovarian cancer. And they were the study is backwards. Something weird happened. We'll skip over it. Okay, so the baseline, they were randomized between mirvetuximab and the name of the investigator's choice of chemotherapy. So the patients were, some were BRCA positive, some were not. That wasn't required, but about 13% of the patients were BRCA positive. Most patients had a primary platinum-free interval of less than 12 months, so they were mostly platinum resistant, and they were stratified by whether they had previously received different kinds of chemotherapies. Okay, and I think it's important to note that most of the patients in this study had received prior bevacizumab. Bevacizumab's brand name is Avastin. Bevacizumab is an anti-angiogenesis antibody that is commonly used. And there were some questions about whether these patients would be able to have the same level of effect with this new drug because they'd previously seen a different antibody. And I think it's, and most patients had had 3 or more prior lines of therapy. Okay, so what we see is our primary progression-free survival. The investigator's choice chemo, the median progression-free survival was only 3.9 months, or about 4 months, which is not uncommon or unexpected. But with the patients that received the MIRV, or the mirvetuximab soravtansine, which is that alpha-folate receptor, they had an improvement in progression-free survival of 5.5 months, 5.6 months. This doesn't maybe seem like a huge change, right? 3.9 months to 5.6 months, but you see that those curves separate and they stay separate, which means that it really, even if they had to go off drug, that progression-free survival benefit was still realized. But what's kind of even more important about that is the overall response rate. So what's really lovely to see is that when overall response rate is really when we're asking, did the drug make the tumor go away? Did it make it go all the way? That's a complete response. Or partially away? That's a partial response. Or did it just stabilize it? The cancer didn't grow. Or did it progress? The cancer grew. So in this study, what's really exciting is that all the different kinds of chemo that were tested, none of them caused a complete response. So for those patients that received investigator's choice chemotherapy, there were no complete responses. The tumor didn't go all the way away. But for the new drug, the mirvetuximab soravtansine, it did. And so for 5% of patients, they had a complete response, which is really radical and very exciting. Partial responses were almost 40%, 37%, and stable disease in 38%. So the clinical benefit, the amount of people that actually really benefit from this, is really pretty exciting. And so the overall response rate was highly significant compared to the 2 arms. You can really see this in what's called a waterfall plot. Waterfall plots look like waterfalls, they're supposed to. And basically, the patients whose tumors respond are below the line. In this case, they're orange, and or on the right side. And in the case of the investigator's choice chemo, they're blue. What you can see is those patients whose tumors grew go above the line, and there are more people below the line, and that makes us really happy. So the more people we can get whose tumors shrink, the happier we are. And you can see that it seems to be a lot better with the mirvetuximab compared with the investigator choice chemo. So one of the things you have to do in a clinical trial is make sure you're right, because bias obviously could make you think that a drug is better when it really isn't. And so they do this thing called BICR, or Blinded Independent Clinical Review. So they look at all the investigators who put patients on the study, and they said, did it really shrink? Was it really better? And so even with a blinded review of all of the data, they came up with pretty much the same thing. So 4.3 months for investigator choice chemo versus 5.9 months for mirvetuximab, which is almost exactly the same, which basically says that the investigators who were doing the trial did their best, and the blinded independent review people said that they agreed. Okay, so here's where it gets very, very exciting. So overall survival. So as I mentioned at the beginning, we've had 30 years of no improvement in overall survival in platinum-resistant ovarian cancer, but now we do. So mirvetuximab demonstrated an improvement, a statistically significant improvement in overall survival between these 2 curves. So mirvetuximab, remember, is orange, and investigator's choice chemotherapy is blue. And you can see that these curves are different. They separate and they stay separate, which means that it's a durable change in overall survival. So this drug seems to benefit some people, and the people that it benefits seem to live longer, and that is the whole goal. So you can see the p-value is really strong. And so how much longer did they live on average? They lived about 3-4 months longer. Okay, so remember I said that the bevacizumab question was, we don't know if patients that get the mirvetuximab are going to do as well if they've had prior bevacizumab or not. And so the investigators predetermined that they wanted to take a look at that question. So they had the statistical power to take a look and say, can I answer this question? So they divided people into people who've never had bevacizumab and folks who had. Folks who had never had bevacizumab had a better response, meaning a longer progression-free survival, than those who did not. And we don't really know why this is. We can hypothesize a lot of things, but we just know that in this setting, it's kind of interesting. So we're thinking about maybe we should use this drug before we move on to things like bevacizumab. So this is the efficacy summary. So compared to investigator's choice chemo, Mirvetuximab demonstrated a 35% improvement in progression-free survival with a hazard ratio of 0.63. If you're super into statistics, we could talk about that. We talked about how it improved the overall response rate. So the chance that the tumor would shrink is 42% versus 16% with standard chemo. And there was a 33% improvement in overall survival, which is probably the most important point. This drug seemed to help people live longer, not just live longer without disease, but live longer. So that's exciting. We will learn more about this bevacizumab question as we do more experiments. How safe was this drug? So, well, it had some issues. So when we talk about how safe a drug is, we divide how bad the side effect is into grades, grade 1 being the mildest, grade 3, 4, 5 being the worst. And basically we can say that this particular drug had some pretty significant side effects that made people feel pretty rotten. In fact, it's doing weird things. We know that 91 people had grade 3 or higher adverse events, but that's actually about the same as it was in the investigator's choice chemo arm, because chemo also gives people some pretty ugly side effects. So it's really about the same. And then how many people had to turn off the drug because they were too sick? It was a little bit less actually in the mirvetuximab group compared to the investigator's choice chemo. So we're not seeing something that's so much harder to take than chemo. The effects are pretty similar. Okay, so from a safety standpoint, we want to look a little bit at the main kinds of safety things that we saw. So we saw some of the classic problems with bone marrow counts, so neutropenia, low white blood cells, anemia, low red blood cells, thrombocytopenia, low platelets. We also saw some numbness and tingling in the hands and feet. That's called peripheral neuropathy, which is very common with these kinds of things, and alopecia, which is hair loss. Gastrointestinal, we saw some diarrhea, nausea, and mouth sores, which we call stomatitis. But we saw something new that everybody was a little bit sort of excited about in GYN oncology, because we saw ocular toxicity. And for gynecologists, the eyeballs are very far from our normal organs of choice. And we were very distressed because we had to learn all of this new eyeball medicine that nobody knew about. So this is a very big deal for us. Keratitis or keratopathy, blurred vision, and dry eyes were the main things we saw. So those are irritations of the eyes, dry, itchy, scratchy eyes, and even some vision changes. Thank God, all the patients that had vision changes were able to have a complete reversal after stopping the drug. Very important. Okay, so what does it mean that we had all this ocular toxicity? So it means that we needed to learn and to support our patients with some preventative eye drops. So what we learned was that we needed to give lubricating drops as well as corticosteroid drops. And so everybody who gets on this drug gets to see the eye doctor before we start to get a baseline exam, and then after cycle 2. When needed, we made dose modifications so that the eyeball stuff didn't get to be too bad, but very few people actually quit the drug because of eye toxicities, which I think is really important. Okay, so what are the conclusions? Okay, in the home stretch, my friends. So the conclusions for this particular trial is that mirvetuximab soravtansine was the very first treatment to demonstrate an overall survival benefit in platinum-resistant ovarian cancer in a phase 3 trial. This is very exciting for us. We know that it demonstrated statistically significant and clinically meaningful improvement in progression-free survival, overall response rate, and overall survival compared to standard chemotherapy. And it gave us some different kinds of toxicity than we would expect to see with standard chemo. Some of it better, a little less neuropathy, some of it worse. Now we have eyeball toxicity, and this is like what we're seeing. It is the first antibody drug conjugate for ovarian cancer and now the only FDA-approved biomarker-directed therapy for platinum-resistant ovarian cancer. So these are kind of practice changing in our world. We're doing a lot more of this now. We're giving a lot of this in our clinic because we understand it better, and it really provides a brand new line of therapy for patients. So we're very excited. All right, thank you. This is a picture of the Michigan Beach shoreline, which is my happy place, and I look forward to all of your questions. And I'm going to stop sharing.
Thank you so much, Dr. Reimel and Dr. Yuan. It has been so enlightening, and you guys have taught us so much. We have received a fair number of questions for both of you tonight, but before we begin with the questions, I do want to remind everyone that the information that is provided tonight by the webinar by both physicians is not a substitute for any medical advice or treatment or for specific medical conditions. You shouldn't use this information to diagnose or treat a health problem. And if you do have questions that are specific to your medical care, the doctors may not be able to advise regarding those specifics, but they would advise that you speak to your own medical provider. With that being said, I do want to jump into some of the questions that we had for both of you tonight, and you can choose who responds to what appropriately. One question that came up, and I believe this was touched upon a little bit when discussing the BRCA positive patients, but are there any new maintenance findings for those who are BRCA negative but facing ovarian cancer?
I'll take this since it's an ovarian cancer question. So maintenance strategies for BRCA negative folks, that's what I heard. Okay, so for BRCA positive people, obviously we have PARP inhibitors. For BRCA negative people and homologous recombination negative folks, we have a bit of a conundrum. So we can give bevacizumab, which I mentioned is an anti-angiogenesis antibody that is used in maintenance therapy and provides a median progression-free survival or more time without cancer of about 3.5 months. Alternatively, we can give niraparib, which is a PARP inhibitor, which actually is still approved for homologous recombination deficient and BRCA negative patients, which provides a median progression-free survival of 3.5 months. So you can kind of pick your favorite. You can also pick to do nothing. Some patients decide that 3.5 months is simply not worth it and the side effects are too great. They prefer to do other things, and we support that as well. But those are our two options for BRCA negative homologous recombination deficient patients.
Thank you. Thank you so much. I believe, Dr. Yuan, this might be for you, that we did get a couple of questions regarding dense breasts and screening for those who are recommended to do screening. Specifically, let's say, every 6 months, alternating various types of screening, but have been found to have very dense breasts, not only just dense breasts. Are those screening modalities still going to be accurate for those types of patients?
Great question. The dense breast tissue, I think most of the patients are screened with alternating mammogram with MRI. So MRI, regardless of how dense breast tissue is, it's actually probably the most beneficial test out there. Yeah.
That's great. And again, sorry, Dr. Yuan, I believe that you did touch on this a little bit, but just to clarify, when we're talking about olaparib and those who are BRCA positive, are there any sort of further survival statistics or information for those patients who are on that drug?
Two settings. So for metastatic setting, the phase 2, phase 3 trial did not show overall survival benefit. I don't believe there's any recent update. I think that it really reflects the options they have. They probably go on to receive other treatment, and it's kind of difficult to tease out overall survival benefit in these patients. But the bottom line is, if the drug is truly phenomenal, like mirvetuximab, it's going to pan out. The signal will translate, not only progression-free survival, will also translate to overall survival. But in our PARP inhibitor breast cancer trial, in the metastatic setting, we did not see overall survival benefit. But in the early adjuvant setting, for patients who underwent neoadjuvant chemo, had residual disease. This is actually only referred to triple negative or hormone receptor positive disease. So the HER2 positive, BRCA positive is a unique entity no one had studied. For those patients, there is overall survival benefit of doing the 1 extra year of olaparib.
That's great. Thank you. And one consistent theme in many of the questions that we received is regarding some of the side effects that come from many of the drugs that are on the market. And are there any was there anything that came out through ASCO that talked about new drugs that might be on the horizon that have lower levels of those side effects?
It's a broad question. If I can tackle, so for example, the patritumab, right? Patritumab, the HER3 ADC we discussed earlier, comparing with, it's the same payload of deruxtecan, but it's targeting HER2. It seems to have a lot less toxicities, because some of the toxicity are so challenging. I had a patient, I vividly recall, who read about the TDXD or trastuzumab deruxtecan information. She said, I'm not going to get on it. I was like, why? Because there's potential risk of ILD. It's scary. So I think comparing with that drug, the HER3 ADC seems to not have a major concern. And the MIRV, it's challenging GI toxicity. As far as, I think in the breast cancer world, there's a lot other ongoing trials, and each single one of them seems to have a unique toxicity. So the Daiichi compound, one of them is TROP2 targeting, but deruxtecan payload. It's called Dato-DXd, and that drug is also unique. It's different from the other two deruxtecan payload ADCs. So it can potentially cause oral mucositis. So patient can have mouth sores. So we don't understand, was it because the mucosa has expression of TROP2, but why we're not seeing it in our sacituzumab govitecan? So I think we're still in the rudimentary phase of understanding the toxicity, but I think the trial data does give us some different flavors of things. So that's why I think when we have all these tools available in clinic, it will be a lot of personalized decision making and discussing with patient according to their treatment history, their current symptoms, or their wish list, right? So there's a lot of wiggle space. So I think that's but in general, ADCs are not toxicity free. That's a message. Although they sound very targeted, very sexy, but they are not spared of toxicities. Yeah.
That makes sense. And then for both of you, one question came in about what role molecular testing is playing in treatment decisions in both of your offices and your facilities.
So for ovarian cancer, the next generation sequencing is more limited, I think, than what's available in other cancers. We have certain things, but there's a fire alarm happening here, so it might get a little noisy. But the issue for us is it's BRCA, HRD, folate receptor. There's a couple of other like NTRK mutations and other kinds of like really spicy, cool things. But beyond that, it's not a huge play. But it's more than it was 5 years ago. So I think that we're going to continue to see stuff happen over time.
Yeah, if I make a comment for breast, we are far behind comparing with lung, but we are making progress. We now have the, liquid biopsy or tissue NGS, next generation sequencing. We can identify ESR1 mutation that we mentioned in our treatment algorithm. We have PIK3CA mutation driven drug, HER3 mutation, HER2 mutation. And then the IHC level will have HER2 low. So I think we're getting a little bit better, but a lot of times patient goes through those testing and come back without any actionable mutation. So just to bear that in mind, not everything we send will come back with a treatment solution. Sometimes they're very frustrating. We don't have that. So it's definitely making progress comparing with 5 years ago.
Thank you. Thank you. Well, that I believe concludes our question and answer portion of the evening. And I want to thank both of you, Dr. Yuan and Dr. BJ Reimel, so much for educating us this evening. I know that you answered so many of my questions, and I am sure that many of our participants feel more knowledgeable after hearing your presentations this evening. As a reminder, in just a moment, we are going to begin our special bonus breakout room for the Embrace community for those facing metastatic breast or advanced ovarian cancer. Anyone who is facing advanced disease is invited to stay on for this intimate breakout session with Dr. Yuan Yuan and Dr. Brigitte Reimel and Bonnie Beckoff, ShareShare's Director of Support Services. Before you transition to that, if you can please take a moment to fill out a brief evaluation survey that's linked in the chat box now. We appreciate it. Evaluations really do inform our future programming, so we thank you for participating. And we'd love for you to stay connected with Share It via social media, where we post about events like tonight's webinar, as well as additional program updates and various ways to get involved. On that note, we would love to have you all join us for our 2023 Share It Summit, which will be this October from the 13th to the 31st. This event, which is nationwide, both virtual and with in-person programming across the country, brings together thousands of individuals virtually and in person in ShareShare's marquee educational event. The link to explore the programming that we have available during that summit period is now been linked in the chat box as well. I also want to again thank our sponsors for tonight's webinar, GlaxoSmithKline, Daiichi Sankyo, Gilead, and AstraZeneca. And please do not forget that ShareShare is here for you and for your loved ones. ShareShare is here to provide emotional support, mental health counseling, and other programs that are designed to help you navigate through your cancer experience. All of our programs are free and completely private and one-on-one. The contact information and where you can reach out to us has also again been linked in the chat box. Our social workers, our genetic counselor are available to each of you, and you are our priority, so please do not hesitate to reach out. And now we are going to transition into our Share It Embrace breakout room. Bonnie, I will